like to congratulate the team at Children's for their success and their Celiac Center for making it really one of the premier centers in the region. And I appreciate the opportunity to be here. So as I was preparing for this talk today, I was thinking about my own experience with celiac disease, starting back, I hate to say this, nearly 30 years ago when I was a fellow. And celiac disease seemed incredibly simple at the time. I was training in Boston, and someone named Michael O'Brien or Sister Margaret would come in, and almost every patient that we saw with celiac disease was of Irish descent, and they had very typical complaints of diarrhea or signs of malabsorption or anemia. And back then, we didn't think that endoscopic biopsies were adequate, so we used to do something called a Rubens tube capsule biopsy. And so we used to take the patients down to radiology, to fluoroscopy, and we passed a tube under radiologic guidance down into the small intestine, unsedated, I might add. And we used a negative hydraulic system to grab a piece of tissue, and then you'd take the tube out and pray that there was a sample there. And so occasionally there wasn't, and we'd do it all over again. And then 3 to 6 months later, we'd go back and repeat the process, and to establish a diagnosis of celiac disease, you had to confirm that there was histologic improvement. So it was quite an ordeal. But that's how we did it. Back then, it seemed very straightforward. We didn't know anything about gluten sensitivity, so it was entirely different. And now, as I prepare for this and I read about and learn more about celiac disease, it's clear that the more that we do know, the less that we really do understand about this disease. And it keeps changing, and it's changed dramatically over the time since I entered gastroenterology. So what I hope to do today is to take on the task that John has assigned me in terms of discussing celiac disease and autoimmune diseases, and we'll run through that and hopefully have lots of time for questions. So I'm going to start off talking about some of the autoimmune features of celiac disease. I'm going to talk about the association between celiac disease and autoimmune diseases. I thought it'd be a good opportunity to mention the issue of malignancy in celiac disease, and finally, I'll comment on some of the screening recommendations for those that have celiac disease. This is one of the most famous quotes by Hippocrates in 400 BC. "Let food be thy medicine, and medicine be thy food." And I'm pretty sure he was talking about a gluten-free diet back then. So let's define autoimmune disease. It's a disease state arising from an abnormal immune response of the body to substances and tissues that are normally present in the body. And a prime example of an autoimmune disease is celiac disease. It's an autoimmune small bowel disease caused by gluten in patients who have genetic susceptibility. In order for celiac disease to be present, there has to be immune activation, which results in intestinal damage, and then a wide range of clinical manifestations. As I said, many years ago we thought that celiac disease was limited to the GI tract, and now we know that 50% of adult patients present with signs of disease outside of the GI tract and other symptoms. As far as celiac disease and other autoimmune disorders go, there's a high prevalence of autoimmune disorders in celiac disease and also in first-degree relatives of those who have celiac disease. It's been estimated that up to 15% of patients with celiac disease have an autoimmune disorder. The risk factors for developing an autoimmune disorder are early diagnosis of celiac disease and those who have a family history of other autoimmune disorders. And we know that gluten-free diet has a protective effect. And one of the questions I get asked frequently is from patients with celiac disease who are completely asymptomatic, and the question is, why do I need to be on a gluten-free diet? And here's one of the many reasons, because it seems to have a protective effect against developing other disorders. So in order for these to occur, there's a theme that'll come up over and over during this talk where, and John mentioned this as well, there has to be a genetic predisposition for these disorders. There has to be environmental triggers. And then, as John pointed out, there's a loss of the intestinal barrier secondary to dysfunction of the intercellular tight junctions and increased intestinal permeability. You need all three for disease to be present. As far as celiac disease goes, we have highly disease-specific IgA and IgG autoantibodies to tissue transglutaminase when there's gluten exposure. There's a process that takes place in the small intestine where small intestinal intraepithelial lymphocytes cause damage to the small bowel lining. And it's thought that early diagnosis and treatment can revert the autoimmune process and prevent complications. So here's a case where celiac disease is different from some of the other autoimmune disorders that I'll mention. Now, the list of disorders that suggest celiac disease grows all the time. So it used to be just gastrointestinal symptoms, but as you can see from this list, there are many other signs and symptoms that are now added to this list. So it used to be malabsorption, weight loss, diarrhea with or without abdominal pain, anemia, and bone loss is actually quite common. Bloating and gaseousness, which is almost every patient I see in my office. Unexplained weight loss, it can be due to abnormal liver enzymes, an abnormal small bowel biopsy when you're studying a patient for other reasons, dermatitis herpetiformis, peripheral neuropathy, mouth lesions, growth failure. The dentist will send in patients with teeth abnormalities and say, can you look for celiac disease, irritable bowel syndrome, and then those that have Downs or Turner syndromes. So those are the common conditions. And then there are some much less common presentations. Most of these are anecdotal, but I'll mention them. Pulmonary hemosiderosis, infertility, dyspepsia, amenorrhea, fatigue, patients who don't absorb their thyroid medications, seizure disorders or ataxia, constipation, and recurrent abdominal pain. And I think for these two lists, we have actually covered every patient I've seen in the last few years. Now, there are two theories as to why there's this association between celiac disease and autoimmune disorders. And neither has been proven, but they've both been put forward and both have their supporters. One is something called linkage disequilibrium as opposed to equilibrium, where the genes that are responsible for celiac disease and associated autoimmune disorders occur together more often than would be expected by chance. The other theory is that untreated celiac disease leads to the onset of other autoimmune disorders. Now, here's the same concept that I mentioned before in a diagram, and you see there are three components. One is the genetic predisposition, the environmental triggers, and the immune regulation. And for an autoimmune disorder to be present, all three factors have to be present. So if you have a genetic predisposition and you have, without the environmental trigger, you won't have the autoimmune disorder. And this is important as we talk about treatments for these autoimmune disorders, because if you can prevent or modify the triggers, then you may be able to prevent the onset of an autoimmune disorder. And again, the same thing. John alluded to this diagram with the leakage through the tight junctions and intestinal permeability, which we won't go through, but it's the same concept. Genetic predisposition, an antigen, and loss of the mucosal barriers that prevent the onset of disease. Now, when you start talking about celiac disease and autoimmune disorders, it basically covers the whole spectrum of medicine. So we've got liver diseases, endocrine diseases, skin diseases, neurologic diseases, rheumatologic diseases, cardiac disease, and then our wastebasket category of other diseases. But I'll mention a few that have been more widely studied than others, more for the concepts than any other reason. Diabetes and thyroid disease are probably two of the best studied. Addison's disease is another endocrine disease, which is adrenal insufficiency, where there's a high prevalence in celiac disease, but in this disorder there's no response to a gluten-free diet. Thyroid disease, it's common to find both celiac disease, and in celiac disease, thyroid dysfunction is also very common. So the prevalence of celiac disease and autoimmune thyroid disease is estimated anywhere from 2 to 7% based on studies. In celiac disease, many patients have either autoimmune thyroid disease or thyroid dysfunction and have a threefold increased risk of thyroid disease compared to the control population. And there have been anecdotal reports of patients with thyroid disease who have normalized after 1 year on a gluten-free diet. That's not the norm, but it's been reported. It usually will not take the place of medications. And there's also an increased prevalence of patients with celiac disease, autoimmune thyroid disease, and type 1 diabetes. And in type 1 diabetes, often the diagnosis of celiac disease comes at the same time that the type 1 diabetes is diagnosed or shortly thereafter. These disorders share the same HLA and non-HLA genetic loci. The prevalence of celiac disease is estimated at 4%. The studies range from 2 to 11%. And the risk seems to be highest in patients who develop diabetes early, less than 4 years of age, and correlates with the longer one has diabetes. And there's also a risk of type 1 diabetes and celiac disease before the age of 20. There's also a second peak at age 84. We now recommend that all patients with type 1 diabetes be screened for celiac disease. As we said, they share HLA genotypes. 90% have either DQ2 or DQ8 versus 40% of the population. And in patients with both disorders, a gluten-free diet will prevent growth failure. It may or may not lead to better glycemic control. One of the reasons is that with the gluten-free diet, you heal the small bowel mucosa, you get better absorption, your sugars go up, and you may actually require more medication. Gluten-free diet does prevent some of the late complications of diabetes, and it prevents bone loss. There's an association between celiac disease and liver disease. Celiac disease in itself is one cause of abnormal liver enzymes. In the three disorders that I mentioned, PBC, which is primary biliary cirrhosis, there's a high prevalence of celiac disease. In autoimmune hepatitis, the patients who have celiac disease do better on a gluten-free diet and may go into a sustained remission. In PSC, which is not a very common disorder, there's also an increased risk. Dermatitis herpetiformis, I'll come back to in a minute. Alopecia areata, there's an association. Vitiligo is more anecdotal and somewhat controversial. Dermatomyositis is another skin disorder. These are the lesions of dermatitis herpetiformis. There's a erythematous sort of papular blister-like eruption, usually on the extensor elbows, arms, shoulders, neck, back. And this was first described in the late 19th century, but it wasn't until 1966 that someone made the association that there was small bowel lesions associated with dermatitis herpetiformis. It's extremely common in celiac disease, occurring in up to 25% of patients at some point in their lifetime. Again, that same concept of an HLA predisposition, there has to be environmental triggers and some disruption in the immune system. In DH, there's active small bowel inflammation with or without GI symptoms. The circulating IgA binds to the skin, and then the deposition of IgA at the skin level causes eruptions that you saw in the pictures. There's a close association between celiac disease and some neurologic diseases. There's something called gluten ataxia, which is a type of movement disorder that's triggered by gluten. There may or may not be small bowel disease. It's thought to account for 36% of cases of idiopathic sporadic ataxia and a high prevalence of HLA-DQ2. And as I said, only a small percentage have GI symptoms in this disorder. And peripheral neuropathies, where people lose a sense of feeling in their distal hands and feet, gluten sensitivity may be present at 34%. 9% of these patients have been found to have celiac disease, and again, high prevalence of HLA types. In rheumatologic disorders, I'll mention the association has been shown in rheumatoid arthritis, juvenile rheumatoid arthritis, Sjogren's syndrome, and lupus. In cardiac disease, celiac disease has been associated with dilated cardiomyopathy and with autoimmune pericarditis. Again, with pericarditis, it's somewhat anecdotal. And then there's a host of other disorders that we'll mention: psoriasis, sarcoidosis, ITP, pancreatitis, microscopic colitis, and enteropathy-associated T-cell lymphoma. In my practice, we do see patients with microscopic colitis. These are patients, typically, I'll say more women than men, in their 50s, 60s, sometimes older, who present with diarrhea. And they don't have Crohn's disease, they don't have ulcerative colitis. When you do a colonoscopy and do biopsies, you'll find inflammation under the microscope, and it's a very well-described disorder, and these patients should all be screened for celiac disease due to the high coexistence. And I'll talk a little bit more about enteropathy-associated T-cell lymphoma in a minute. So in celiac disease, there is a slight increase in mortality over the general population. It's usually shortly after diagnosis in those who have failure to respond to therapy. We think this implies a beneficial effect of a gluten-free diet. There's a slight increase in non-Hodgkin's lymphoma, including both B and T-cell lymphomas. Small bowel adenocarcinoma is found more in celiac disease than the basic population, but it's a very, very rare type of cancer. And enteropathy-associated T-cell lymphoma, half of those are diagnosed at the time of their diagnosis of celiac disease. It's a very rare complication. It makes up less than 1% of lymphomas and has a very poor prognosis. There are two types of refractory celiac disease, type 1, type 2. This lymphoma is found in type 2, usually within 5 years of the diagnosis of refractory celiac disease. What makes it difficult to diagnose is that the symptoms are basically those of celiac disease: pain, diarrhea, weight loss. The median age is 60, equal distribution between males and females, and may also occur in patients who do not have celiac disease. 25% of those are at more than one location, usually in the proximal small bowel. So as far as monitoring celiac disease, given this multitude of other disorders that are associated, here's what we typically do. At diagnosis, we monitor serologies until they normalize. We also assess nutrition at the first visits until the abnormal lab values normalize. We recommend a bone density within 2 years of diagnosis. Liver enzymes should be checked at the time of diagnosis and every 1 to 2 years. And the same with thyroid function tests. We don't always go back and do a duodenal biopsy. And we do cancer screening for patients with celiac disease the same as in the general population. So mammograms, PSAs, colonoscopies, pap smears. And so what I've hoped to show over the last few minutes is that the response to a gluten-free diet is variable. There's cause and effect between celiac disease, gluten, autoimmune disorders, which has not been proven and often is anecdotal. And as I said before, a genetic susceptibility. The antigen must be present to trigger the immune disruption, and then loss of protective functions of mucosal barriers. So I'm going to end there and allow time for questions. I'm ready.
Okay, I just want to make sure I understood. Are you saying that there really are no scientific reports based upon research to support gluten-free diets and other autoimmune disorders besides celiac?
It depends on the disorder. So, it's, you know, in some, yes. So in thyroid disease, for example, there are patients whose thyroid dysfunction resolved after 1 year on a gluten-free diet. It's not, it doesn't happen to everyone, but it has been reported. Certainly in type 1 diabetes.
Do you have an actual way that I can figure out where that scientific research is?
Sure. If you email me, I'll send you the references.
I'll find you. Thank
Okay.
you.
We have another question over here.
And I think it's related. I was diagnosed with dermatitis repetiformis back in '75, a long time ago. So, but I was not put on a gluten-free diet until several years thereafter. I was taking sulfapyridine for the symptoms, so were bad symptoms. The gluten-free diet cleared up the symptoms. I've never been tested for celiac. But now that I've had a gluten-free diet for over 40 years, is there any reason for me to be tested for celiac when I understand I probably have to eat some gluten to
No.
be tested?
So there is one way of testing people on a gluten-free diet,
And by the way, if the only answer is stay on your gluten-free diet,
which is what's going to be recommended. But if you wanted to know whether or not you carry DQ8 and DQ2, we can now test for those markers. But that's, which is what I usually do first in patients who come to me suspicious that they may have celiac disease, but we don't want to put them on a gluten-free diet.
If there's a really wide range of symptoms that may not even be digestive, and then also a really wide range of autoimmune diseases that anecdotally are found to be present in patients with celiac, how do you think that the medical community can respond to prevent situations like this or mine where I had juvenile arthritis for 10 years, but then being diagnosed with celiac and going gluten-free cleared it up?
So, first of all, back in 1975, it wasn't as well known that there was this association. So DH back then may have been a little bit different. Now, it's so easy to get antibodies for celiac disease that most pediatricians and internists will obtain them. I mean, they're readily available. So most patients who come to me have already been screened for celiac disease.
Just kind of a quick follow-up though, I've heard actually that a lot of patients experience a lot of pushback from either their rheumatologist or their primary care doctor who says, I think that's an unnecessary test. Even my dad, his daughter had celiac disease, the doctor told him, I think this is unnecessary, but once he got it, it was positive. So I guess my question more is amongst.
So we need to educate our colleagues, basically.
There's a question online, actually.
Yeah, we have a couple of. Okay, yeah. No?
I got it.
Okay, we got it. We do have a couple of really interesting online questions. One is about refractory celiac disease. What can we do about that if we have this patient experiencing refractory celiac disease?
So refractory celiac disease is a very complicated disorder. So, I mean, the first thing to do is you have to eliminate gluten to be sure that there's no gluten in the diet. So you really have to do a very thorough evaluation because in the old days, where people weren't as familiar with gluten-free products and so forth, most causes of refractory celiac disease were from gluten exposure. And if you've eliminated gluten exposure, then you really need to see a specialist to go through and discuss, because there are treatment options available, but we're talking about immunosuppressive therapy and so forth to control the symptoms.
Our second question from the online universe is there a connection between celiac and Crohn's disease?
Yes.
Can you
it-
expand on that slightly?
Well, so it may not fall technically under the what we're talking about today in terms of autoimmune disorders, but there's clearly an association. I do have patients in my practice with both celiac disease and Crohn's disease. It just makes treatment a little more challenging.
Okay, and our last online question is, well, actually there were two questions about celiac and Crohn's.
Okay.
Popular. And then one about non-celiac gluten sensitivity. Can that affect the immune system in any of the ways that you talked about here? And is there a way to actually diagnose that?
There is no test per se for gluten sensitivity, and whether it can affect the immune system is, I would say, controversial. I'll leave it at that.
We have a couple more questions over there.
Question about microscopic colitis. I saw Dr. Fasano back when he was in Maryland, and I HLA-DQ2, but was never confirmed celiac, was already on the diet, and he said to me, we used to believe celiac disease was confined only to the small intestine. Now we know that the large intestine is involved, and he suggested that I should consider myself celiac based on my lymphocytic colitis diagnosis and my genes. Would you agree with that?
I think it's semantics. I mean, I don't know that I would say celiac disease involves the colon, but clearly there's a colonic disorder that's been biopsy proven. I would say that both disorders coexist.
We have another question.
What blood test can you run to find the markers that you're talking about, B2 or the?
It's a
It's just
genetic
the
profile
IgA.
it's a genetic profile that's available through either LabCorp or Quest.
Okay.
So you would just
So it's
basically
not the same as the IgA?
no, it's a different test, but it is readily available.
Okay.
Do you find a correlation of, I was diagnosed with an autoimmune disease early in childhood when I was 13. I had my firstborn, and then I got celiac. Do you find a correlation with people who have been diagnosed with autoimmune already and pregnancy, using that as a trigger to create celiac? I had no problem eating gluten until after I gave birth, and then I got diagnosed. And do you find there's a correlation? Do you have other patients like that triggers it?
Yes,
or is it
because
more popular because of the autoimmune already with being diagnosed early in childhood?
you know, I've seen patients diagnosed with celiac disease as late as 75. So
Do
here
you
you.
think pregnancy though? Have you seen that with a pregnancy?
Well, this was a
triggers?
nun, so I'm pretty sure that she had not been pregnant. But, I mean, it's just, there has to be some trigger. So if you don't have the right environmental trigger to sort of set this off, then it may not be present.
We have one more question over there.
I believe I saw on one of your slides that you should be tested again, biopsy, 1 to 2 years after being diagnosed.
There are some people that do that, and in my practice, if patients have an excellent response and their serologic markers go back to normal, I see no reason to repeat the biopsy.
So once you've had one and you're diagnosed and you're doing gluten-free, skip it?
That's my practice, so I
Okay.
can't speak for everyone.
Because my question was, what is the benefit of having it? I'm going to continue to eat gluten-free because my symptoms have disappeared.
So in this day and age where the markers are readily available and the antibody, you can get antibody levels, I don't, but the recommendations are slow to change in terms of people sort of accepting that as the gospel.
Well, we appreciate your time, and we're going to wrap things up and take a quick break. We have one more presentation left.